Dr. Jin Wang, Dr. Mark Hongdin, Dr. Yang Xu, Dr. Luke Yong, and Dr. Huawei Amutfu. They will give us a lecture of the leading edge knowledge of the medicine. We will have ACAP honorary and ceremony tonight in ACAP Gala. We honor the people and organizations who tirelessly and selflessly contribute to our community and ACAP in the past and today. I would like to take this opportunity to thank you, all of you, to attend the convention, especially thank to the youth students to participate ACAP Science Fair competition. Tonight, we have ACAP Science Fair Finalist Award ceremony to congratulate the winners. It's my honor to announce the 27th Association of Chinese American Physicians Convention open now. Thank you very much.
These are daily trends in the number of COVID cases in the U.S., and you can see there were spikes corresponding. The most recent one was the Omicron variant. So needless to say, a very significant disease still. I know there are separate talks on pathology and some other talks following this, so not to belabor sort of the virology and pathogenesis of of COVID, but we understand that the source of viral entry is by attachment to the ACE2 receptors via the spike protein, and these ACE2 receptors are primarily located on the respiratory as well as vascular endothelial cells. After the virus enters the cell, there's DNA or RNA replication, viral replication, assembly, and then further release of viral particles. And therein starts the generation of disease. COVID, as we know, it causes quite a spectrum of illness. So that ranges from asymptomatic or pre-symptomatic patients, which are characterized by people with a positive COVID test, so positive virologic test, but really no symptoms. Mild disease, very common, especially with the most recent Omicron variants, consists of people who obviously test positive for COVID. They have symptoms, and I listed some of the symptoms here. Common things: fever, cough, sore throat, so like viral URI type symptoms. Loss of taste and smell, which was very common in the initial waves, and I think it's seen a comeback with some of the newer variants. However, these patients with mild disease do not have shortness of breath or abnormal chest imaging. Then moving forward, people who are have moderate COVID have the above, previously mentioned symptoms, but they also have lower respiratory findings. So positive chest X-ray, positive CT scans. However, they are typically not hypoxemic. So their saturations usually, arbitrarily, the lower bar has been defined as 94%. So these patients typically do saturate above 94% on room air. Moving along the spectrum, when we get to severe disease, now these are your patients who are hypoxemic. They have low sats. They may meet criteria for ARDS. So this is the P to F ratio, PaO2 to FiO2. Typically that's less than 300. They may be tachypnic, again another sign of respiratory distress, and they do have significant lung infiltrates, which usually defined as over 50% on whatever imaging modality is being looked at. And then finally, the final stages, obviously, these are the critically ill patients, and these are the patients who are in fluid respiratory failure requiring mechanical ventilation, septic shock, or multi-organ dysfunction. So a really wide range of disease severities, and unfortunately, as we all have seen, patients can progress from being asymptomatic mild to then critical illness. This is just a pictorial representation, sort of combining everything that I was just saying, putting on a timeline of when, symptom onset, the incidence of mild, severe, and progression to critical illness, as well as, the clinical situation. This green or turquoise line here represents the, intensity of viral replication. As you guys can see, this it's highest in the initial sort of possibly pre-symptomatic phases. Okay, So, and lastly, I also, wanted to mention, obviously, these are the high-risk comorbidities that are associated with higher risk for progression to severe disease. So not to say that everybody with COPD or diabetes will have severe COVID, but patients with these comorbidities are at higher risk for developing more severe illness. All right. And I just included a quick slide on some of the classic imaging findings. Obviously, this is by no means comprehensive, but classically, the chest X-ray actually may be normal, or initially at least. There have been several papers, many papers actually published describing the CT findings of COVID, CT findings in COVID. Some of the common ones are these peripheral bilateral ground glass, consolidation. So that's this first CT scan here. So you can see these are infiltrates that are really in the lung periphery. Typically, again, located in the basal parts of the lung. There's a lot of ground glass, but there may be consolidation as well. It's also been described as crazy paving pattern, which is ground glass with visible intralobular lines. That's an example of that is the second picture here. So you can imagine these little, the ground glass, and then they're sort of being outlined by the intralobular septa. This last picture here is just an example of when patients go into severe COVID or ARDS. This is actually very similar to patients that we see non-COVID ARDS. Their CAT scans may often look like this. What I didn't show is that, and we are still learning more about this, is there's a lot of, many of these patients may go on to develop fibrosis post the initial or post their recovery, and this may happen several weeks to months after the initial disease. That being said, we do have many patients who obviously recover without any sequelae. So it's a very interesting disease, to say the least. Okay, now moving on to sort of the meat of my talk, which is the management and treatment of COVID-19 infection. So the first, and I structured these in sort of order of severity. So firstly we have mild disease. Obviously the people who test positive have no symptoms, they do not require treatment. Patients who have mild COVID, most of these patients can be managed in the ambulatory setting. Depending on the situation, they may be offered sort of telehealth visits. Again, treating and seeing COVID patients requires a lot of coordination just because of the concern for infection and spread of illness. Typically, no imaging or specific labs are recommended, and we just offer symptomatic management. So for cough, for fever, maintain hydration, etc. Very importantly, I do want to mention, and this has sort of gone back and forth, and there was a lot of there was a lot of attention to this, but currently no steroids are recommended unless there's signs of unless there's another indication. So somebody has a concurrent asthma attack, somebody who's on steroids already baseline for some other reason. We do recommend to monitor the older patients and those with the underlying comorbidities because again, they are at higher risk for progression to severe disease. If you feel like your patient does qualify for treatment, the currently recommended therapeutic options are listed here, and I will go over each of those in a little bit more detail. So the preferred treatment is the Paxlovid, the ritonavir boosted nirmatrelvir. I think the pronunciation is a challenge today. As well as the one of the SARS-CoV-2 antibody treatments, the bebtelovimab. There's also another oral antiviral medication, molnupiravir, and then remdesivir. So I'm going to go over these really briefly in a little bit more detail. Starting off with Paxlovid. So this is a protease inhibitor. The main active drug is actually the nirmatrelvir. It's boosted with ritonavir, which is a inhibitor of the inhibitor of the P450C. 3,4-A inhibitor, so that increases the levels of nirmatrelvir to a therapeutic range. A similar mechanism is used in HIV patients where they have the ritonavir as a booster to their other heart therapy. So Paxlovid received the EUA from the FDA in December of 2021 for the treatment of mild COVID outpatient. I just put in data from one of the bigger trials. There have been others looking at Paxlovid, but And probably the most sort of important one was the EPIC-HR trial, which was a phase 2 to 3 randomized placebo-controlled trial that showed 89% reduction in hospitalization and death in patients with symptomatic COVID who were taking Paxlovid versus placebo, in whom the medication was started within 5 days. Just an interesting note. At the time when these trials were done, all of these patients were unvaccinated. So that's, a slightly different situation than we are in now, but unfortunately this is still only one of the few sort of therapeutic options we have for outpatient therapy. So the dosing, really quickly, you have to take many pills, so you have to warn your patients that there's a lot of tablets to take. It's 300 milligrams of the nirmatrelvir with 100 milligrams of ritonavir taken twice a day for 5 days. It can be taken with or without food. The tablets shouldn't be chewed, they shouldn't be broken or crushed. You do want to dose reduce for patients who have some mild renal dysfunction, and some of the common adverse effects, GI, so nausea, vomiting, patients may experience this, diarrhea, elevated blood pressure has been described, as well as myalgias and dysgeusia. But generally, okay tolerated. Some drug-to-drug interactions, you guys are probably all aware of this, but there are many drug-drug interactions. I just listed a few of the common families of meds.
Here, these are my disclosures. Thrombosis in COVID has been a very widely talked about topic since the beginning of the pandemic, and is one of the more recognized complications, particularly in the very ill population that we saw earlier in the pandemic, the inpatient population, the critically ill population. And recognizing that the shape of the pandemic has changed in the last 2 years, I want to bring everybody through where we've been, talk about some of the early findings that led us to understand that thrombosis was an escalated risk in patients with COVID, and bring it up to the present to understand not only the inpatient population, but the outpatient and ambulatory population as well, because that seems to be the predominant group of patients that we see with COVID now. And there are different considerations for preventing thrombosis in those less sick patients. So if we go back, I know it's probably not something we want to think about, but going back to the beginning of 2020, when we were really just becoming familiar with COVID, it was very early on that we recognized that thrombosis was a major complication among the sickest patients. There were case reports and retrospective data from many countries early on that showed very wide variation in rates of thrombosis, but regardless of the actual numbers, it was very clear that these rates were many times higher than what we had seen in the traditional inpatient medical population. Depending on where the studies were done and the cohort of patients, we saw rates of thrombosis sometimes exceeding 50%, particularly in critically ill ventilated patients. So it was very obvious early on that this was something different, and something that hadn't really been seen even with very severe respiratory viruses that we'd encountered in the past. There were other concerning features as well, above and beyond the high rates. Number one, we were seeing a lot of undiagnosed DVT and a lot of undiagnosed pulmonary thrombi at time of autopsy. In some cases, upwards of 60% of patients on autopsy had evidence of in situ pulmonary microthrombi. So this was highly concerning because, as we know, one of the dreaded complications of COVID is worsening respiratory failure, ARDS, leading to death. And could this be implicated in that process? A further concerning factor that we knew early on was that this was not just related to venous thrombosis. There were also many arterial thrombotic events that you would not normally see even in a critically ill population. Furthermore, we encountered what has now been termed this concept of breakthrough thrombosis, meaning finding thrombosis in patients who were receiving standard of care prophylaxis. So all of these features combined clued us in very early that this was a new phenomenon and something that required a different prophylactic approach if we were going to avoid bad outcomes in the COVID population. some of these early studies were very successful in identifying risk factors that we could use to stratify patients and start to think about new prophylactic strategies. In some cases, they were clinical risk factors, clinical features. In other cases, people used validated risk scores that have previously shown to predict risk of clotting very well pre-pandemic. One such score that I'm familiar with that I've used in my health system and has been externally validated, in hundreds of thousands of patients across the country, is something called the IMPROVE score. This is a relatively simple 7-factor model that incorporates well-known risk factors like prior VTE, cancer, which we know is a risk for clotting, immobilization, thrombophilia diagnosis, things that we have traditionally associated with thrombotic risk. And what we went about doing was validating that risk score that had been shown to be very good in the non-COVID population, in the COVID population as well. And we were able to do that. And the model, was fairly good at predicting risk of thrombosis in the early wave of the pandemic. One notable feature of this, which I would ask you to keep in mind because it's going to figure very prominently in the rest of the research you see, is that an additional risk factor, and at this point it's probably going to come to a surprise to nobody, was elevated D-dimer levels. We've talked and heard a lot about elevated D-dimer. Previously, before the pandemic, we used it to rule out low probability PE in patients who came in with suspicion of PE and thought maybe we don't need to do imaging, we can just rule out with a blood test. But D-dimer has actually been shown to have prognostic value as well in predicting thrombotic events in COVID, and it is exquisitely sensitive. So this is going to be one of the things that a lot of the research you see is anchored on. So this was the state of affairs prior to the research that I'm going to show you. Even up till, let's say, a few months ago, the recommendations were standard of care prophylaxis for inpatients. But what I hope to convince you of in the coming slides is that that obviously has reason to be changed, and in fact is changed now for good reason. Apologize for this slide, but what I wanted to show you was that subsequent to those guidelines, there have been many randomized trials, upwards of 20 randomized trials looking at this question, because we knew that standard of care prophylaxis was inadequate. So the obvious question arose, should we be giving a higher dose of a prophylactic agent, such as heparin, low molecular weight heparin? Would a higher dose do better? And related to that, is that something that all COVID inpatients needed, or just some COVID inpatients? How do we stratify? So there have now been many trials. I'm going to take you through a few of them quickly, because as I said, we've kind of figured out what to do in the inpatient setting, and the questions really remain in other populations. But what I want you to keep in mind when I go through a few trials is the trials tend to fall in a couple categories. In one category, the investigators looked at prophylactic agents like heparin as traditional, in the traditional design of an antithrombotic trial, meaning can we use a dose of heparin to prevent large clots, DVT and PE? And can we prevent death? There are other trials that I'll tell you about that don't look at those as the primary outcomes. Other trials look at whether we can use anticoagulants to prevent disease progression in COVID. So for example, when I was mentioning earlier the autopsy and pathological findings of microthrombi, there has been this lingering theory for probably 20-25 years now that microthrombi may be precursor to worsening respiratory failure and can be treated with higher doses of anticoagulants. I'm sure there are some of you who remember the days of Zygris, the activated protein C product that was used probably 15-20 years ago in critically ill patients with respiratory failure, and was thought to be a good adjunct treatment for exactly this reason, the presence of microthrombi and maybe the need for anticoagulation. It was later removed from the market due to safety concerns. So that kind of theory has kind of resurfaced in the pandemic, that maybe this time will be different because the disease is so prothrombotic maybe there's a role. I thought that was a very bold prediction because it hadn't been really shown before. But nevertheless, some of the trials I'm going to show you act on that theory, that maybe the microthrombi leading to ARDS and respiratory failure can be mitigated by higher doses of anticoagulants. So not really in the vein of a traditional antithrombotic trial, but more preventing disease progression and the need for organ support like ventilation. So it's an interesting kind of mix of studies, and I'm going to take you through a few of them. I'll try to be brief on the details because, again, this is for the inpatient population, and we're mostly focused on outpatients these days. The first trial that was presented was the Inspiration trial, which looked at critically ill patients. And what it looked at was the effect of intermediate dose heparins compared to standard of care. There was a range of doses used in this, but you could think of it as basically a double dose. Instead of, the usual dose of, say, 40 milligrams of enoxaparin once a day, it would be twice a day. Something along those lines, but it was based on weight. And what they found was that in the critically ill population, this did no better than giving the regular standard of care in terms of preventing thrombotic outcomes, as well as measures of disease progression like need for ECMO, and of course cause mortality.
How do I know I will have severe COVID after the breakthrough infection? The second common question. But last, as few people ask, how do I know I will be ICU after breakthrough infection? Now we look at some information. New England Journal published several months ago first show anti-spike IgG level is critical for people to prevent severe disease. That's the first paper published based on Israel data. The Israel study, they focus on healthcare workers. They found 2 doses of mRNA vaccine in age less than 50 years old. That means younger age, but not older age, okay? Breakthrough infection rate only about 2.6%. That shows vaccine is very effective to reduce infection. If people without vaccine, the infection rate will be 100% almost. So that's why I say vaccines are very useful to reduce infection rate. Asymptomatic in their cases is about 67%. In Wuhan cases, about 80%. Breakthrough infection association with if people have lower anti-S-IgG after 2 dose mRNA vaccine, it's predict breakthrough infection. So this is very important. First time mentioned, testing may be necessary based on clinical trial. Now, I point out the first publication in the JAMA Internal Medicine, right? Summarize United States data. So post-vaccination test is necessary, especially for vulnerable people. Regular people, maybe not. Those people with post-vaccination will have very effective monoclonal antibody therapy, I will mention later. Our own data published in the China show about 10% of non-response to vaccine in general population. This is the first paper published show general population and cause scientific attention. But we only summarize 2 doses of inactive vaccine. And we found that in the younger age, about 7.5% not very well response, and 11.7 in the old age. So roughly, we have similar finding in previous paper, but with different vaccine. So boost, that's we make a suggestion very quickly. Boost should be recommended for non-response quickly.
That's the paper published in the mRNA. So we get similar data. About 10% general population is non-response to vaccine after 2 doses. Okay, that's why I suggest we need a third dose, maybe 4th dose, based on individual immune response. And also pay very attention to cancer patients. They found the people with lymphopenia, 50% not respond very well in the cancer patients. Also in the cancer patients, age larger than 66, not very well. Especially in hematology patients, much, much worse. So hematology patients is very vulnerable for infection after COVID vaccine. So primary physician maybe watch out the lymphocytes counts. If this one is very severe, for a very low lympho count, need to pay attention to this patient. So now I summarize the current, very predominant situations of BA5 or BA4. So what should we prevent, treat with COVID variant currently? So we suggest immunity test may be necessary for vulnerable people because BA4, BA5 is a brand new viruses. And the monoclonal antibody available against BA5, I will mention later. And N95 mask published in New England Journal show very good to prevent vulnerable people in endemic area. BA4, BA5 vaccine, currently we have it, may be very good for caretaker or vulnerable people, because if a caretaker get infected BA4, BA5, these vulnerable people are very harmful. And the COVID antigen test in the home to caretake may be benefit. That's the CDC currently treatment guideline for BA4, BA5 infection. Those recommendation for treatment non-hospital adults. So anti-SARS-CoV-2 therapy as preferred treatment for COVID-19. The first mentioned Provax. So Provax still show very important to prevent the COVID cases. Second thing is the anti-CoV therapy as alternative methods means Provax maybe not work or not suitable. These drugs could only be used need of preferred treatment available. So these drug list, the first will be beta-lobit MMB. That's the only one currently show approved by FDA can effective against BA4 and BA5. That's the data published by David Ho. It's HIV people who create cocktail for HIV therapy. And his data show Blovil MMB, another name called LYCOV1404. They have IC50, about 123 nanogram per ml. This is the data show. They can against alpha, BA1, BA1 1.1, BA2, and BA45. So that's when we can use this one for effective to against the current variant. That's the FDA presented data, right? Before approve BA4, BA5 mRNA. Look at these data. use the lung and nasal, and we can see control and compare with currently new vaccine. They have very effective to reduce viral load and increase protection. And why FDA will approve BA4 and BA5 without clinical trial? Because mRNA have been shown very safe. That's the first they show initial data and jumping to approve BA4, BA5 vaccine. So BA4 and BA5 in FDA website announced August 31, 2022. However, NBC News just mentioned that they're different voice, with the FDA gamble on new COVID booster without clinical trial. But we will see what's going to happen. The Moderna COVID-19 vaccine bivalent and the Pfizer BNT COVID-19 bivalent contain mRNA from SARS-CoV viruses. The mRNA vaccine, in these vaccines, is special pieces of genetic material that instruct cell and the body to make distinct spike protein of original virus and an Omicron variant lineage BA4 and BA5. Why we call BA4 and BA5?
It's very contagious to others. So the way it works is once we have the skin solution, the scalp get fall off, and then the fresh layer of the skin get come up, then you can say now it's safe. So it's quite different from shingle that what we saw, because the shingle is as long as the first, all the skin get healed up, then it's fine. Then we can call it for, okay, good luck, bye, and then we just give like medications, finish the course, yeah. But for monkeypox, it's quite different. So it takes time. It's usually say 7 to 14 days, but some people, depends on how severe this lesion is, it could take a month too. So that's why the isolation, the precaution is very, very important, especially for us. I think for all these medical providers here too, yeah. When we see patient in our clinic, you have no ideas when they come. They just told you, oh, I have this thing, and then when you ask more question, you feel like, oh, they may kind of high risk, yeah. So at that time, you really need to protect ourselves and also protect your employees too, yeah. So this is the picture that I show. This is the 2003 the monkeypox outbreak, and this is the endemic country. If you see the distribution of this skin lesion, it's quite different too. Yeah, so make us very, very confused. When we make the diagnosis. This is the May and this one is the May and June 2022, which is the current outbreak. And this is the genitals area, rectals area. If you look at this, it's very look like HSV or syphilis or anything, Okay, so more picture can speak 1,000 words. Look at this distribution, is very, very different, It can be in the finger, I mean, we used to call what the hepatic vein broth, with these people who get this who get this kind of wall in our things, yeah. Like here, yeah. Usually the people who get it is like dentists, I think. Okay, so what condition that we need to know? Because of this, it's very confusing with the STI. By the way, we don't call STD anymore, yeah? So up to last year, we call STI rather than STD, yeah? I mean, it's better for us, The infection is better to we prevent that to persist to the disease, yeah? So anyway, so very confused with STI. And also, I told you about the shingle things, yeah? But one thing I want you to keep in mind is the STI diagnosis does not exclude the monkeypox infections. And infections may be co-occurring too. So once you find out this patient, let's say they have syphilis, it doesn't mean that the patient doesn't have monkeypox. the other way around, you know, if they diagnose it with monkeypox, that could be another things that on top of that. A perform a full skin mucosal exam is a must, so with a good lighting, yeah. So what we're talking about is not just looking at the hands and the skin and everything. We need to check the anal, we need to check the regional, especially the labia, you know, that can hide, and also the oral, the mucosal too. I will tell you why later on, yeah. The lesion, they actually progressive from papilla macular vascular. That's the picture that I showed you before, and then at the end it will become a scar that's fall off, and then the new skin will form. Yeah. So those are the things that. And then also obtain a detailed sexual and travel history is also very important too. Yeah. It's not only to let's say if they have high risk of getting infections, but also to determine if they need a pre or post prophylaxis vaccines. Complication. So I mentioned about the proctitis. Yeah, this is a very difficult thing because we all know chlamydia, one of the subtypes of LGV, L1 and L2, L1 to L3. Yeah, that can also cause proctitis too. Yeah, for GI doctors here. Ulcerative colitis, that could be very confusing too, yeah. For people who have HSV, to people who have rectal cancers, you know, all these can cause rectal pain, yeah. So the good history is very, very important. Cellulitis and abscess, that could be happens when because the lesion is not only pain, can also itching too, yeah. So when you scratch enough, hopefully not, and then you will form the cellulitis, and then like soft skin infection, and then develop this abscess. Good thing that when we had this kind of patient, actually the proctitis was like the rectal abscess was really, really big when we do the CT scan. We lucky that. In our facility, we have an infusion center, so we're just giving IV antibiotics, and then after course, and then we change to PO. This is the one I want to mention, ulcerative pharyngeal lesion. That is another reason why with the TPOXX medication, they also come in two forms. One is IV, the other one is PO, because some people, they cannot swallow at all. So a detailed oral mucosa examination is very important. Conjunctival lesion. So basically, if you look at this is actually hit on every single system too. Yeah, the lung, the brain, the heart. You know, even though the pineal necrosis, this is very. I mean, when we talk about this, we were talking about complication, talking about the severe disease, not really like common in the general population. So who will be with, you know, for this severe monkeypox things? People who are immunocompromised, you know, like renal transplant, kidney transplant, HIV patient, or any autoimmune disease, or even like severe skin disease too. Yeah, people who are pregnant, you know, I mentioned atopic dermatitis, and young children too. Yeah. So this is the slide. I did it in purpose. I put it here because I want to emphasize here. If you look at here, this is the first year of the COVID-19 pandemic. If you look at this number, it's horrible. We have 2.4 million cases of chlamydia, gonorrhea, and syphilis, and then 1.6 million of chlamydia, which is the one that I told you about, the proctitis, one of the cause from this chlamydia too. Yeah. So very, very horrible. I mean, if you think about this, because if you look at all this like penetration, you know, like mouth, the mouth lesions and genital lesion and all these things, you know, very, very confusing for us to do the diagnosis. So here I have a list of infections, non-infectious, and diffuse rash, and anything that can possible cause proctitis. I will just leave it here. You know, another picture, secondary syphilis, you know, very serious soldiers, you know. And this is very, very crazy too. If you look at this, I don't know, I'm so sorry. So if you look at this umbilical lesion, yeah, if you just look at this lesion without getting any history, this is an uncontrolled HIV patient have a disseminated cryptococcus infections. So as I said, we really need to do a good exam, and I mean, of course, in addition with the get a detailed history. So if we have this case in our clinics or urgent care, which I think most of the medical providers here may possible see this kind of patient, yeah. So a mask you need to wear, and of course I mentioned this before. If it's possible, you can put him in a room that isolated, yeah. As for now, in general, beside you're in the hospital, there's no like specific requirement, you know, for the air handling. Otherwise, you know, don't use any like portable fans or dry dusting thing, because those kind of things will actually make the virus falling in the air, and then people can actually breathe into. So wet cleaning method is better. At the bottom one is his number for this provider SS9. So any doubt that in terms of the suspected case, in terms of management or treatment, or even like the vaccines, or you need to get a consultation.
With hypoxia requiring admission to the neuro ICU. In addition, the average duration was a little bit higher, and of the 8 patients, like I said, 3 patients progressed to a GCS of 3, which was almost brain dead, actually brain dead, with evidence of cerebral edema and severe ARDS, and 2 were declared dead, and the goals of care discussions were being conducted for the 3rd case. The rate of mortality in or end of life in the ICU in the COVID-19 patients with cerebrovascular involvements was approximately 37%. So as you can see, it's pretty high, compared to 24% if they did not have neurologic disorders. 2 of the deaths were actually due to patients who had dissections. And I think part of the reason we were able to identify this is because, in addition to neurocritical care, I do neuroendovascular surgery. So I will look at, like, one of the things I will always do is I will always look at the blood vessels. So I'm actually very carefully evaluating the blood vessels of all of these patients. This was obviously, there were some limitations to this. It was a single center study. The rapid evolution of the pandemic did not allow us for like long-term follow-up, because like many of the hospitals you probably work in, we had patients who were transferred from literally 6 hours away because no other hospital would take them, like upstate New York, and they would essentially come to us. So I had no way of following up many of these patients. This basically led us to another international study that I led with one of my partners, Dr. Kandawal at Rutgers University, and this was an international study that evaluated patients in all of the, in 12 COVID-19 hotspots. These were in New York, New Jersey, Italy, Spain, and China. And this was using a group, the Chinese COVID Research Consortium. And what we found were, we evaluated almost 7,000 patients with COVID-19 globally. 88% of those patients actually had ischemic stroke. 66 were large vessel occlusion, so large vessel was blocked in the brain. 42% underwent, 42 patients, or 63% underwent endovascular thrombectomy. And 19 patients undergoing mechanical thrombectomy were under 50 years of age. So that was kind of interesting. Unfortunately, again, just like many of the, these are patients who are coming in with symptoms, and it wasn't entirely clear when a patient with COVID presented at that point, was presenting to the hospital, it wasn't entirely clear that the main focus was, let's try to manage his COVID, not really realizing the patient was complaining of numbness in one side, or was a little bit weaker on one side. So we weren't scanning their brains, we were checking their chest x-rays. When they came in with severe COVID or severe neurologic deficits, we'd get a CTA of the head and neck. And as we're scanning the neck, you'd actually see the APCs of the lung, And it was in these cases where actually diagnosing COVID. We subsequently, because of this, I actually started looking at like other manifestations, vascular manifestations of COVID. And one of the things we found was RCVS. We actually reported the first case of reversible cerebrovascular vasoconstriction syndrome and dissection in the setting of COVID-19. This was published in Stroke, and you can see over here, you can see it over here, but basically the vessel, like this vessel should be like getting smaller, but what's happening is there's loss of cerebrovascular autoregulation, and there's some areas where the vessel would actually dilate and vasoconstrict, and unclear why. And over here you can see this patient actually had convexity subarachnoid hemorrhage. This was a very young patient who was admitted to us, and you actually see this patient also had a dissection over here. But unless you're really looking for this, this will be missed. This, in fact, was like, with all due respect to my radiology colleagues, this was missed by our radiologist. So, as you can see, the research that we were doing was like, one thing was leading us to another thing, and one thing we found was I decided to conduct a meta-analysis. So we conducted a meta-analysis of all of the COVID-19 studies that were published to date to identify, and here we found almost 11,000 patients. Out of 11,000 patients, we reviewed, again, 22 studies, 17 case series. We excluded a lot of patients who did not mention or did not really look at acute cerebrovascular disorders, but those that did, we actually, what we found was we found 2.6% incidence of development of acute cerebrovascular disorders amongst consecutively admitted patients with COVID-19, and 6.5% incidence of acute cerebral amongst patients with severe COVID-19. So if you came in, which again coincided and correlated very nicely with the studies out of China that described approximately 5% acute cerebrovascular disorders. But what we found was, overall of all patients with COVID, it was almost 3%, 2.6%, and of all patients with severe COVID, it was approximately 6.5%. In patients with severe COVID, those patients, if they had history of a stroke, they were 12 times more likely to have comorbid cerebrovascular disorder. So you're 12 times more likely to have another stroke. And the mortality rate was almost 35% in patients if you had a cerebrovascular disorders, which again correlated with the numbers that we found at Westchester. So we've always been talking about acute ischemic stroke. But as many of the people in, many of the audience would attest, that we were also talking about DVTs and PEs. And as we were talking about this, as a person who deals with acute COVID from a critical care perspective, and I deal with the blood vessels in the brain, one thing that occurred to me, I was like, well, how do we know that they're not having, just like they're having PEs, how do I know that they're not having clots in their sinuses, in the venous outflow of the brain? Because there's no explanation. Why does this patient have global cerebral edema? So I actually embarked on this study that we led, looking at, this was a New York metropolitan cohort study. And the thought was, COVID-19 or SARS-CoV-2 induces hypercoagulability with inflammation, leading to increasing procoagulant clotting factors, and disruption of the normal homeostasis of vascular endothelial cells, resulting in microangiopathy, local thrombus formation, and a systemic coagulation effect. The main risk was we're not really moving these patients, right? They're developing DVTs, and hence these clots are showering to the lungs, and they're developing PEs. But is it possible that it's a more systemic, it's not only due to lack of mobilization, it's probably due to a diffuse hypercoagulable state. So we actually did the study. We published this in the in American Journal of Neuroradiology. During this period, we actually found almost 13,000 COVID-19 patients. 12 patients had imaging-proven CVT. The demographics and clinical characteristics I'll show in the table next. There was a wide range, of age from 17 to 93 years of age, amongst a subset of patients. 44% were actually younger than 40 years of age. And that is actually in line with what we see for cerebrovenous sinus thrombosis. Those patients tended to be younger. What was really interesting was, although typically those patients are usually female, in this case it's like 2-to-1 female to male ratio to develop a clot in the sinuses. In this case, we actually found male to female ratio was reversed. It was almost you were 2 times more likely to develop a sinus thrombosis if you were a male than if you were a female. Hispanic and Caucasian patients account for almost 90% of the patients, which is likely, in my opinion, like a reflection of the demographics that we included in the New York metro area. So one of the things, and this was actually an excellent point that was brought up by one of the reviewers. They said, well, how do you know that those patients weren't just hypercoagulable to begin with? Maybe they had a hypercoagulable disorder. Did you guys check for factor V Leiden? And of course we didn't. Like those were patients where, this is in the middle of a pandemic, like nobody was checking this. But what we actually found was only 2 patients were identified who had prior prothrombotic risk factors. So as far as the symptomatology was concerned, 85% had headaches, 50% actually had unilateral weakness and seizures. Cortical signs were noted in 25%. Fever and cough was the most common symptom attributed to COVID-19. And mechanical ventilation was required in 41% of the patients. And the median duration of ventilation was almost 15%. We treated with anticoagulation almost 83% of cases, 10 out of the 12 patients, and 2 were treated with endovascular thrombolysis. Hemicraniectomy was also performed in 2 patients. So, in conclusion, CVSD was associated with COVID-19 was an exceedingly rare occurrence, with 10 case reports available at the time of the writing of this manuscript at the time. Historic incidence rates were 0.22 to 1.5 per 100,000. And
these are actually benign. It doesn't mean having benign pathology is, you're off the hook, because benign pathology can still have high-risk implications. For example, patients with atypical lobular hyperplasia, or ALH, or lobular carcinoma in situ, LCIS, have a lifetime risk of between 10 and 20%. For LCIS, breast cancer risk is bilateral, and most cancers occur more than 15 years after diagnosis. So screening for these patients is incredibly important. For ADH, patients do have an increased breast cancer risk, but to a lesser degree than LCIS. Women with dense breast tissue, as determined by mammography, not by physical exam, are 4 to 6 more times more likely to develop breast cancer than women with fatty or scattered breast tissue. And increased breast density also decreases the sensitivity of mammography for the detection of small cancers. So it's important to know if you have dense breasts. In New York State, it's a law that you have patients get a letter that say if they have dense breast tissue. A history of radiation exposure to the chest between the ages of, I think, younger than the age of 20. Like for example, mantle radiation for lymphoma is associated with increased risk of breast cancer. And actually the breast cancer risk for a Hodgkin lymphoma survivor treated at age 25 will be 20 to 25% by the age of 45. And these patients are recommended to begin annual screening mammography at age 25, along with annual breast MRI. A personal history of breast cancer. The 10-year recurrence rate is 19.3%, and the risk for contralateral cancer is 0.5 to 1.1%. 0.5 to 1% per year during the first 10 years after diagnosis. Also, the age of diagnosis matters. Women diagnosed at or before the age of 50 that opted for breast conservation therapy, meaning they do not have a mastectomy, have a 20% or higher lifetime risk for a new breast cancer. Increased estrogen exposure is also associated with increased risk of breast cancer, and any factor that increases in the number of menstrual cycles a woman experiences is associated with an increased breast cancer risk. So this includes early menarche, late menopause, nulliparity, delayed, older age and having your first child. So patients that are actually spend a longer time being pregnant, that's actually going to be protective against breast cancer risk. We also know that hormone replacement therapy is associated with an increased risk of breast cancer, and combined HRT, estrogen, and progesterone is associated with a greater risk than just estrogen alone. This is most significant with use over 5 years, but appears to return to baseline a few years after discontinuation. This is similar to long-term greater than 10-year OCP use, and again the risk dissipates after discontinuing use. Other things associated with increased risk for breast cancer include obesity, smoking, alcohol. Also, individuals with a higher socioeconomic status are at increased risk of breast cancer, which I thought very interesting. And the reason for that is that maybe this patient population, they have fewer children, or they that's really the biggest one that I could find, is that we tend to have, people who are of a higher socioeconomic status, and white women tend to have children a little bit later in life, and that actually makes women at increased risk for breast cancer. So speaking about race, and this is something that I really, really wanted to touch on. So white and black women have the highest incidence of breast cancer. However, black women are 19% more likely to die of their disease. So I went to an entire conference talking just about the differences between race and breast cancer and outcomes, and I found this to be staggering. Also, non-Hispanic black women have death rates 39% higher than non-Hispanic white women. So why does this happen? Well, possibly insufficient access to mammography and healthcare, which is something that we're working to solve across the country, delays in diagnosis and treatment, but also is tumor biology. So black women have a higher incidence of triple negative breast cancers. And a recent study showed that 22% of black women had inherited mutations that might have explained why they were younger when their breast cancer presented, and also had more aggressive breast cancers. So I just thought that was very interesting, and this conference I went to actually, they actually looked at different areas in Africa and different genetic mutations, and how that tied into presentation of breast cancer and tumor biology and patient outcome. It was really very interesting. So the ACR and Society of Breast Imaging recommend that all women discuss their risk factors with their healthcare providers beginning no later than at age 30. And of course, this is incredibly important for women of color, minority women, and Jewish women. As Ashkenazi Jewish women, 1 in 40 are BRCA1 or BRCA2 positive. So this is incredibly important for primary care providers, because now women are being encouraged to come and to talk to the primary care providers about what is my breast cancer risk. So how do you know if your patient is high risk or have a greater than 20% lifetime risk of breast cancer? Well, it's a great question, and we'll discuss ways of triaging patients, but there are certain patients who should always be considered high risk. And for me, as a radiologist, what that means is if you're older than 40 years old, you should be having a screening breast MRI with or without contrast every year. So this includes women who are BRCA1 or BRCA2 positive, and a woman with a history of chest radiation between the ages of 10 and 30. So this is at the Mayo Clinic, and this is a breast cancer risk assessment, a stepwise approach for primary care providers in the front lines of shared decision making. And this article aims to assess an individual woman's risk for breast cancer and help primary care providers efficiently generate accurate risk assessments in order to make appropriate screening recommendations, because it's very confusing, and I thought this might be really interesting for you guys to take a look at, because it really does go about like a stepwise fashion. So step 1 is to assess family history. So the United States Preventative Service Task Force, I think I got that correct, and the NCCN, they have, of course, as always, different guidelines on what to do. But what I thought was interesting was that UPSTF recommends a family history screen or breast furrow screening tool, and these are available online to help you ask your patients about their history of breast cancer. And then depending on whether or not this is positive, you can refer your patient to a genetic counselor. the NCCN and ACAP advise that clinicians ask patients about all cancer diagnoses, including first and second degree relatives, including the age of diagnosis. And if this family history is positive, those patients should be referred for genetic counseling and genetic testing. If those patients are then found to be BRCA1 or BRCA2 positive or have a higher than 20% lifetime risk of breast cancer, they will begin a high-risk screening protocol. If your patient denies genetic counseling, or if the family risk assessment is negative, then you would go on to assess personal history. So key personal risk factors, like we discussed before, can be divided into demographics, such as race, ethnicity, age, hormonal and reproductive risk factors, including age of menarche, menopause, number of pregnancies, hormone use, also breast density, breast history, have you ever had a breast biopsy, what was the pathology of that breast biopsy, and then again to ask about a history of radiation therapy to the chest between the ages of 10 to 30, because those patients are automatically high risk. And then number 3 is to choose a risk prediction model. Well, there are plenty of them, and it's kind of tricky to figure out which ones to use. Basically, the most 3 common ones are the NCI model, the VCSE model, and the IBIS, also known as the Tyrer-Cuzick model. The last one is actually the most comprehensive, but is the most difficult to use because it's incredibly long. There can be a lot of input error, patient error, user error, and it has been shown to underestimate disease risk in some populations and overestimate risk in some populations. And then, of course, number 4, interpret risk assessment. So, if greater than 20% lifetime risk of developing breast cancer, as a radiologist, we're going to recommend annual screening mammography with or without supplemental breast ultrasound. And this is to start 10 years before the onset of the youngest first-degree family member, but not before the age of 30. And also screening breast MRI. I also think it's important to note that women with an intermediate risk of breast cancer, between 15 to 20%, maybe if you have personal history of breast cancer, LCIS, ADH, these patients may benefit from screening mammography before the age of 40, and they may also benefit from screening breast MRI. However, the consensus on this, it's all over the place. No one can really agree on what to do with these patients, and so I think a multidisciplinary, approach is appropriate.
And today, I would like to take this opportunity to thank you, all of you, to attend the convention, especially thank the youth students to participate in ACAP Science Fair Computation. Tonight, we have ACAP Science Fair Finalist Award ceremony to congratulate the winner. It's my honor to announce the 27th Association of Chinese American Foundation Convention open now. Thank you.
Multi-local cystic renal cell carcinoma, and this is tumor that very distinct growth and morphologic features. And back in 2004, I was just asking the diagnosis. It's not particularly difficult, and just more etiology. Well, you should put it as criminology, those kinds of things would be kind of interesting. So back in the 2004, the tumor, multilocal cystic renal cell carcinoma, was put in under clear cell renal cell carcinoma, where they're parallel, it's different and separate. And this is the morphologic features of this lesion, and the growth rate they have very this lesion, and you have to see those clusters of the aggregates of clear cells in the septies. And those morphologically, those cells will be identical to what we see in traditional classic clear cell carcinoma. So this is more local cystic renal cell carcinoma. The name will be familiar from decades. You practice GE pathology in this case. That's been a change. Lots of renal cell carcinoma, gangliocytes, like that. Unclassified reflecting like your knowledge, but you don't know how to do it. So I like to change.
Could you put the microphone closer?
Yeah.
I cannot
Okay,
hear from
yeah.
the back.
Okay, yeah. Okay, so this is So this in this case, this is the clear. So this case in the past was called unclassified, and actually this is new knowledge, new entity that we group have defined. This is called capillary renal plasma with vertical polarity, and the one of the most interesting finding in morphology is that the tumor have really have kind of a nucleoli it's more towards the luminal surface. There's a papillary architecture, and those are keratin GAT3 positive. And one thing is very, very unique to this tumor is that the KRAS mutation. How often you can think about this is just really this truly the molecular signature of this tumor. 80% of the tumor we found carry the KRAS mutation, and so. If you read the modern pathology, that's what's released last month, and it's the cover story of that issue. This paper was just published last month. We further defined this molecular this tumor, and we found that there's actually in addition you can find in the kidney specimen, there's also precursor issues that if you pay attention, you study those so-called papilloadenoma, and you will find much large number of cases. Actually, they have very, very similar morphology that we see in this tumor, renal cell with polarity, and you can see here, this is some typical structure. The tumor is like very used in the case of plasma papillary structure. The tumor really they have more nucleoli reversed. More towards the luminal surface of the papillary structure. So this is a new entity that our group has further defined. I will have to thank the KenLee He's one from resident, stand resident and fellow, and now he's working in the Henry Ford Hospital. He's really truly one of the best fellows in the training. He's the one which if we go back to the 2004 WHO classification, you probably noticed there's a tumor called multilocular cystic renal cell carcinoma, and this is tumor that very, very distinct growth and morphological features. And back in 2004, I was just asking about the diagnosis. It's not particularly difficult, and just more etiology. What you should put it, what's terminology, those kind of things to be kind of interesting. So back in the 2004, the tumor, multilocular cystic renal cell carcinoma, was put in under clear cell renal cell carcinoma, where they have parallel, independent, and separate. And this is the morphologic features of this lesion, and this growth rate, they have very, this lesion, and you have to see those clusters of the aggregates of clear cells in the septies, and those morphologically, those cells will be identical to what we see in traditional classic clear cell carcinoma. So this is a multilocular cystic renal cell carcinoma. The name may be familiar from decades if you practice GE pathology in this case many 10 years ago. And the tumor is kind of somewhat interesting. Morphologically, that if you took the individual single cells, they will be identical to clear cell renal cell carcinoma. But if you do staining, and it's nothing 100%. It can be CD10 active and also CT7 CT7 positive. So they have very kind of interesting morphological features. And in terms of how about molecular cytogenetic findings, and this study we published 10 years ago. And what we found is that this tumor carried typical, unlike clear cell renal cell carcinoma, multilocular cystic renal cell carcinoma, indeed, those cells will have 3 key deletions, and that's hallmark of clear cell renal cell carcinoma. So with that, we thought this tumor is probably category. Here's in the 2016 WHO classification. What we can see here is that, again, you will see this other one also is 2016. The multilocal system neoplasma, there's two things you probably noticed. The name change. In 2016, it's been changed to multilocal system neoplasma of low malignant potential. So that's the name that has been adopted, and in 2016, that's more reflecting the the indolent biological behavior of this tumor. And again, in this case, in the 2016, the multilocal system neoplasm of low malignant potential was put under that's the same parallel as clear cell was distinguished. And here, we really kind of this paper was talking about we thought really from pathogenesis point of view, because they're sharing a similar morphology as well as cytogenetic findings, the multilocal system neoplasm of low malignant potential really should be put under clear cell and we probably just based on the similar morphology and the cytogenetic findings. Indeed, in the most recent WHO classification, fortunately, we can change the name again. That's always good things. I don't really think my personal opinion is that the science is not different, but terminology changes. And so in this case, we retain the terminology, but we put multi-local system neoplasm of low malignant potential under clear cell neoplasm. I think it's a good tumor classification-wise, so put the same tumor category in the some difference. One thing I'm going to talk too much about it is another thing is the type of renal cell carcinoma. So in the new WHO classification, finally, and still somewhat controversial, we drop the top one, top two classification. You may recall in the CAP. Not the most recent. I think the guideline we want you to put in specified type 1, type 2. Now officially the type 1, type 2 classification has been dropped. So we are no longer needed to copy to give the type of peritoneal carcinoma, which is say skip the formal nuclear. That's an additional change. This is kind of one of the interesting tumor, and so it's actually this tumor that we're getting the cover story of the modern pathology, and the tumor is very, very distinct morphology. There's they have kind of pseudo-rosette, tubules, acinized, and some bluish, some almost became put into small blue cells. And also have a classification. Each time when you see classification, you always think about papillary renal cell carcinoma, translocation renal cell carcinoma. So one clue that you don't diagnose.
At my sign out, I feel like this is not going to be sign out today. Okay, so let's start with some easy ones. This is a 79-year-old male with bilateral renal masses. So even under this low power, nuclear features. What you do not want to see are the nuclear grooves or irregular nuclear contours. You want to see pretty rounded nuclear contours. So this we're comfortable with. If you're not comfortable, you can always run a CK7 and should be patchy positive or entirely negative. So this is not a very hard one. This is renal oncocytoma. However, on a biopsy, because we all have seen resections and part of it to look like renal oncocytoma. So this is the time you want to look at the imaging studies and see if it's like a 2 centimeter mass or a 17 centimeter mass. So if it's 17 centimeter mass, you might not want to call it renal oncocytoma straight out. You may want to say this is a renal oncocytic neoplasm, but I do favor it's a renal oncocytoma because a 17 centimeter mass, maybe this is the focal area and the rest of it, you're not seeing it. So I think it's safer to just call it renal oncocytic neoplasm. Again, you can always say I favor it being renal oncocytoma. So the only caveat, and also because we're a cancer center when we see all kinds of patients, is that when you see renal oncocytoma or in that spectrum like renal chromophobe or hybrid tumors, especially in younger patients, you might want to think about your Burhout-Dubé. So just very briefly about Burhout-Dubé, we all have heard about it. There's many other organs that can be involved. You can have leiomyoma in the skin. You can have pulmonary cysts that cause pneumothorax. It is a disease that can have different manifestations. Some family members can have really early on setting of everything. Some others only later on present with kidney tumors. So this is something we, especially in younger patients, we do put in the comment that, especially also in bilateral renal tumors, that maybe they want to consider testing the patient for Burhout-Dubé. This is another case, also a very oncocytic looking tumor. It's a 57-year-old male with gross hematuria. It's a 17 centimeter mass and also retroperitoneal mass. So before you even look at the slides, you probably do not want to consider oncocytoma. It's probably already out of the picture. So under low power, it's very oncocytic. There might be some hint of microcystic. And I just want to say that some of these tumors, they give you all these structural descriptions, but on the biopsy, it's very hard to put that into context, because biopsies, I guess sometimes you can have structure, but it's very hard. So under higher power, again, if you use some imagination, you might have some vacuoles in the cells, and that's also described in this entity. So this is our panel of immunostains. I found that the top 5 are very important, very easy. So with the top 5, you should be able to tell all your common tumors, your clear cell, your papillary, your chromophobe, your clear cell papillary. You should be able to decide based on all these. If you couldn't decide based on the morphology. So when you look at your oncocytic tumors, though, then you need to add some more. So we add CK20 for the cystic, we add SDHB, FH, and now we have 2SC. That's also for the hereditary leiomyomatosis renal cell carcinoma. And this panel on the bottom is for translocation tumors. So in this case, the SDHB is lost, but you always want to look at a field that has your positive control. So you don't know if your immunostain didn't work. So you really need to see some positive stainings, and in contrast, your tumor cells are negative. So this is the patient, the same patient. Remember, he also had a retroperitoneal mass. So this is his retroperitoneal mass. It looks neuroendocrine, kind of. And this is GATA3. So the GATA3 was positive, and synapto and chroma are both positive. And this is also negative for cytokeratin. So this was a retroperitoneal paraganglioma. So this family of renal cell carcinomas are called SDH-RCCs. The mutation can be in SDHB, which I guess is the most common. There's also SDHA, C, and D. And they can be associated with pheochromocytoma and paraganglioma syndrome. You can have all the other kind of endocrine tumors. And you can have a potential for malignant paragangliomas. And the likelihood, believe it or not, for RCC is not that high, but compared to general population, it's already high. The bad thing is it's an autosome dominant tumor. So 50% of the future offsprings are going to be affected. So if you have one case of SDH, the whole family need to be tested. This is another case. So the first thing striking again is that the age. This is a young woman and has an abdominal mass. So when you think about your young patient population, you probably have to think about your syndromic things. So even under medium power, this is not very informative. I'm not sure what the characteristics are here, other than there's some necrosis. This is the thing about biopsy again. There's a lot of artifacts. The cytology sometimes are not very useful. So higher power, again, you always try to see what categories can you put into for these tumor cells, but they're not very informative other than the necrosis. So this is an aggressive tumor. May not be clear cell, right? Because it doesn't look very clear. May not be papillary, but we're not seeing any papillary structures. So probably one of those things you don't really sign out every day. So this is PAX8, and why are we doing PAX8 in the kidney? I'm going to talk about that later on the second category, but some of the things that you don't think of, especially when it's strange, you might want to first think about, is this even from the kidney? So PAX8 is positive. And this is myelin A, strongly and diffusely positive. TFE3 is positive. I do agree with Dr. Chen. TFE3 is a very tricky stain. It's not very clean, and sometimes it's not very strong. So you don't really know when it's focal, when it's patchy, is it true, is it not? So all the cases that we call translocation, we do have FISH confirmation. We don't really, if just based on immuno, we suggest that, but we do not really strictly call it translocation carcinoma until we have FISH. So this is another case. This is a case of the same category, another type. It's a 24-year-old, again, very young, has abdominal discomfort and very large kidney mass. Even under this very low power, you can see some calcification. So this is a characteristic for this tumor with the calcification. So medium power, sad to say, because this patient actually passed away, but it's a beautiful looking tumor with all these, kind of round ball structures with some space in between. And under higher power, what is described is two biphasic tumor cells. Some are large, some are intermediate to small. This is cathepsin K. So we do like cathepsin K. It's a very specific stain. It's not very sensitive. It doesn't stain all translocation tumors, but when it does, it's actually very, very specific in our hand. So again, going back to the immunopanels, if you're thinking about your translocation, I think keratin is very, very helpful, because keratin is supposed to be negative or very faintly positive in these tumors. And we do use TFEB and TFE3 as screening stains. Again, these are going to be, if they're positive, we will do FISH to confirm. And HMB, if you don't have TFEB and TFE3, HMB45 and myelin A are helpful.
Markers for the urothelial carcinoma. So as we know that we have 100 years experience based on the morphology, and I think pathology did a pretty good job to give the diagnosis and all the for the patient clinical treatment. But the problem is that how to follow up the patient, and as we know, the urology is probably one of the high-paid subspecialty. The reason for that is that for all the urothelial carcinoma and for the follow-up, golden standard is use the cystoscope to get into the bladder and take a tissue, and so pathology can make the accurate diagnosis. So the tissue is quite expensive, and the cystoscope is definitely not fun for the patient to do that. So we urgently need more differentiation. The most common one is the squamous differentiation, and followed by the glandular differentiation, and small cell differentiation, and the trophoblastic differentiation. And for the subtype, Brio put variants, and also has many. And the morphology is in a very big spectrum. So in our daily practice, we should be familiar with this morphology and to make the right diagnosis. So squamous cell carcinoma differentiation is the most common one, and it occurs in 20 to 40% of all urociliary carcinoma. And there are some important clinical indications, and also there's a TCGA data indicate that the basal squamous cell subtype may link to the better response for the certain chemotherapies. And on the other hand, we also have a squamous neoplasm of the bladder, is including the pure squamous cell carcinoma. Even though not everybody believes in American, we have this entity exists, but that's still in the textbook. And second one is verrucous squamous cell carcinoma and squamous cell papilloma. So papilloma should be easy. So based on morphology, we should be able to distinguish from the carcinoma, but sometimes it can be difficult. The practical question is during the small biopsy or the transurethral resections, we have the carcinoma with squamous differentiation. So usually what we do is we just say high-grade carcinoma with extensive squamous metaplasia and C node. And in the node we can say this differential diagnosis including the urociliary carcinoma with squamous differentiation, and also could be representative of the very rarely the squamous cell carcinoma of bladder or squamous cell carcinoma from the other origin. Okay? And the second differentiation is the glandular differentiation, and in the most common situation, so we always see the conventional urociliary carcinoma accompanied with the glandular differentiation, and they also have a different morphology, including the single ring cell and the mucin pools. And so usually we have to, if we see this lesion, we should document in our reports. And there's one study the pure urociliary carcinoma versus the urociliary carcinoma with glandular differentiation, and the prognosis has no difference. But we still recommend to put this in the report because once the urociliary carcinoma get metastatic and they form in the glandular lesion, so that's sometimes get confused. If you document that in the report, and that make the following pathologist's jobs much easier. And this one is a very interesting entity. It's called, there's two names. One is carcinoma in situ, and the second name is much longer, but it's more preferred. It's the high-grade urociliary carcinoma, non-invasive with glandular differentiation. So this initial study is done by the Epstein's group. So what they found that these cells it doesn't look like urociliary. Actually, cytology look like columnar cells. And that gives the whole impression is glandular differentiation. So they have four architectures. The first one is glandular, second one is cribriform, and the third one is flat, and the last one is papillary. And initially Epstein used the carcinoma in situ, but he got criticized because if he used this name, that's implied. And this is the precursor lesion of the bladder adenocarcinoma, but actually it's not. This one is usually associated with high-grade common urociliary carcinoma. So then he created a second terminology called high-grade urociliary carcinoma non-invasive with glandular lesion. Even it's very long, but it's more reflect the nature of this disease. And so the glandular carcinoma so can be forming different. So this one is almost forming the single gland without cribriform. So that's could be sometimes could be challenging. So here is one of the famous benign mimicker of the cancer. This is nephrogenetic adenoma. It's a complete benign, and usually the clue is that this lesion is usually very small and located mucosa and in the submucosa areas, and usually has a very extensive inflammatory backgrounds. And so the immunostaining PAX8 can be used if you have any doubt. You want to confirm that this lesion is a PAX8 and diffuse strongly positive, and sometimes can be cytologically, actually can be very scary. Looks like almost like single ring cell carcinoma. Okay. And so glandular lesion in the bladder has a broad differentiate diagnosis from complete benign reactive change to the metastatic. And so, okay. So the secondary adenocarcinoma involve the colon, involve the bladder. The most common one in both male and female is colon cancer. And actually, primary adenocarcinoma bladder, we cannot distinguish by immunomorphologically versus the colon cancers. So sometimes in this situation, we really write notes, and so we just convert the message, say they have to work up on the colon. The third one is the neuroendocrine differentiation, so that includes small cell carcinoma, large cell neuroendocrine carcinoma, and well-differentiated neuroendocrine tumor and paraganglioma. So I think prior two speakers all mentioned the paraganglioma. So this one is not common, but it should be kept in the differential when you see some morphology and indication for the paraganglioma. And small cell carcinoma is rare. It's only less than 1% of the all bladder carcinoma. And just like the counterpart of the lung small cell carcinoma, once they diagnosis small cell carcinoma of the bladder, usually there's a lot of patient already has metastatic somewhere else. So it's important to make this diagnosis because sometimes an initial presentation probably you have very extensive urociliary carcinoma, and small cell carcinoma is only small proportions. So so keep that in mind. If you see suspicious area, even it's not necessary, but always recommend to do the immunostain to confirm the neuroendocrine features. Because later on the patient may present metastatic small cell carcinoma, and if you don't document it in the report, and they have to do all the whole body scan imaging to find where's the origin of the small cell carcinoma originally coming from. So here is the example showing you that the both component conventional urociliary carcinoma next to the small cell carcinoma. And recently we did one study, because we know the lung small cell carcinoma has been well studied, and the molecular feature of this non-small cell carcinoma has co-inactivation of the TP3 and the RB1. So clinically right now we use the TP3, RB1, and the P16 because P16 can be extensive positive because the RB1 loss in the lung small cell carcinoma, in addition to the conventional neuroendocrine carcinoma. So my question is that we know that morphology. If you're not sure the morphology, always do the immunos, and for the urociliary marker, never use the only one markers, and usually you use the GATA3 and CK5/6 at least for these two markers. And additionally, for the paragangliomas, we cannot tell the prognosis based on morphology. But about 20% will be recurrent or the metastatic in later stage. This is very real entities, and you can see the urociliary carcinoma is forming the syncytial trophoblast morphology, and sometimes even pulse for HCG, but this is a very real entity of the urociliary carcinoma. Okay, and for the architectures, there are some well-known.
Into the proximal stomach stage as gastric cancer. So this used to be 5 centimeters and now changed to 2 centimeters. Again, it's a little bit difficult if the patient has neoadjuvant therapy. The lesions is hard to be identified. So the 2 centimeter rule is sometimes not very helpful. In that case, radiology before the neoadjuvant treatment and the clinical impressions whether this is esophageal cancer or gastric cancer are helpful. Now another kind of definition, kind of conditions usually kind of mentioned to you is early gastric cancer versus advanced gastric cancer. So early gastric cancer is defined as tumor invading mucosa or submucosa, so T1A and T1B, with or without lymph metastasis. Even with lymph node metastasis, it's still early stage. Regardless of the size of the tumor, it's still early stage. Those tumors are usually have excellent prognosis. 5-year survival rate is more than 90%. The main treatment for early gastric cancer is endoscopic resection or gastric. Now, advanced cancer is cancer invading beyond the muscular structure. So into the muscle or beyond T2 plus is advanced cancer with or without metastasis. So the treatment for this advanced cancer is usually neoadjuvant treatment plus gastrectomy. The prognosis is 5-year survival rate is about 60%, so significantly worse than early cancer. Now, gastric adenocarcinoma is the most common malignancy in the stomach, greater than 90%. Worldwide, it is the 5th most common cancer and 3rd leading cause of cancer-related mortality. The overall gastric cancer rate has declined. However, the cancer in the gastric cardiac region is increasing. The risk factors including H. pylori gastritis, EBV infection, alcohol smoking, autoimmune gastritis, and dietary. So most of those cancers are sporadic, but 10% is developed in a familial kind of setting. Early gastric cancer diagnosis can be challenging. Frequently, you don't see a distinct mass lesion. Usually, it's just erosion or kind of ulcer in the stomach. And histologically, you see this glandular with surface erosion, inflammation. Is this reactive change or is this cancer? So you have to look at the morphology carefully. This is pretty complex. The glands are touching to each other. You have frequent luminal necrosis. If you look at the other area, the same case, you will see this anastomosing gland with marked cytologic atypia. So this is early stage adenocarcinoma. Now, higher power, in the same region, you can see the nuclear features really ugly. You see the large nuclei, nucleoli, and there's no laminar propria between the glands. So it's back-to-back glandular formation, sometimes we call endless glandular pattern. Now, this is another example of early gastric cancer. On the left side, you see this, the surface looks relatively intact. You may see some low-grade dysplasia here, but on the left side, you see this infiltrating pattern. On the right side, it's kind of diffuse infiltration by some kind of cells. So, look at the glandular area. So this, again, the surface looks relatively intact. The adenocarcinoma part, you see the anastomosing glands angulated. So the glandular component, they kind of anastomose into each other. You have this horizontal and perpendicular kind of glandular formation, and you see this nuclear subluminal necrosis. So this is a well-differentiated adenocarcinoma. On the other area, you see this infiltrating cells between the glands. All the glands, you see these infiltrating cells. Not all of them have nice mucin. If you look around and see those kind of mucin containing malignant cells. Again, if you have questions, a simple diagnostic thing can help you make a diagnosis. Now, the classification of gastric adenocarcinoma, we have histological classification and a newly molecular classification. Although Lawrence classification was developed in 1965, all clinicians are still kind of get used to this type of classification, and their early treatment is depending on the intestinal type versus diffuse type. We have the new WHO 2019 classification that's a little bit different from 2010 classifications. So you can see intestinal type in our classification. We have papillary, we have tubular, we have fully differentiated for indifferent. Diffuse type is fully cohesive, ring cell type. or other cell type, and then mixed cancer types. There are several other histological subtypes, which include adenosquamous carcinoma, carcinoma with lymphoid hyperplasia, hepatoid adenocarcinoma, and some undifferentiated carcinoma. So all those kind of classifications. Now, just briefly, intestinal type adenocarcinoma in the Lauren and the new WHO classification called tubular adenocarcinoma. I'm not sure nobody likes this terminology. We don't use tubular adenocarcinoma in our diagnosis. It's kind of confusing with tubular adenoma, and we still use adenocarcinoma intestinal type. So this is the most common subtype of gastric adenocarcinoma. You see this sleeve-like branching tubules and similar to chronic adenocarcinoma. Sometimes you see there's a change or acid formation, but this is the most common one. Now, papillary adenocarcinoma is also in the Lauren classification as a carcinoma type. This type of cancer is not that common. It's about 2.7 to 9, about 10%, less than 10%. So grossly, they show kind of exophatic growth. You see the papillary formation in the branching of glands. So this type of cancer, they have high frequency of liver metastasis, poor survival. So it's important to recognize this papillary adenocarcinoma. The diffuse type in the Lauren classification in WHO we call fully cohesive single ring cell type or other cell types. So this accounts for 20 to 50% of gastric cancers. Typically, you see single cell or fully cohesive malignant cell infiltration. There's no risk factors. They appear to arising in different pathways. Intestinal type, as we mentioned, about 10% of gastric cancers, they are hereditary cancers. They are diffuse cancers involving CDF1 gene. Now, mixed adenocarcinoma accounts for 6 to 22% of gastric cancer. Basically, it includes two distinct histological components. So you can have tubular papillary with single ring cell or polycohesive, any of those combinations. It's important to recognize it and report it, the different components. Again, because the mixed type usually have a little bit more prognosis than just single one component. Indeterminate type in Lauren classification with mucinous adenocarcinoma is about 2 to 8% of gastric cancer. So it's like the mucinous adenocarcinoma, colon or other GI tract. You see the glands or sometimes single ring type of cells and then pools of mucin, more than 50% of the intramural cells. So again, this type of cancers have a mutation profile that is typically involving KRAS or BRAF mutation, and the prognosis is poor. Now we mentioned there's a special type of gastric cancer, gastric carcinoma with lymphoid stroma. So this is a cancer that's related to EBV infection. It accounts to 1 to 7% of gastric cancers. Traditionally, it's called an lymphoid epithelioma-like carcinoma or medullary carcinoma. So it has very characteristic histological features. It's male predominance.
Taking service, we frequently say eosinophilic GI disease that are either missed or overdiagnosed. So because there's no good consensus on some of the disease entities, so let me. I don't have anything to disclose. So let me start with a case. This was a 44-year-old woman who had a new onset of rectal pain and bleeding. Colonoscopy showed multiple small erosions and then and ulcerations in the in the cecum, ascending colon, and rectum. The rectal mucosa was also erythematous and friable. So this was a biopsy from the cecum. As you can see here, the mucosa, the biopsy shows ulceration with granulation tissue, and then even at this power, you can see there are numerous eosinophils here. And here's the rectal biopsy. There's no evidence of erosion or ulceration in this particular piece. But the number of lung-appropriate inflammatory cells is apparently increased. Even in this medium power, you can see there are numerous eosinophils. This is also from the same patient. The biopsy was from the terminal ileum. Again, there are tons of eosinophils. So if you just look at this, you may think about the eosinophilic gastroenteritis because eosinophils are so numerous. So the way most people would make a diagnosis of eosinophilic gastritis or eosinophilic colitis or enteritis, just based on the impression, okay, there are so many eosinophils. Oh wow, there are so many. So I'm going to call eosinophilic esophagitis, eosinophilic gastritis, eosinophilic colitis, stuff like that. But and then we asked them, what's your diagnostic criteria for eosinophilic, for example, eosinophilic esophagitis, eosinophilic ileitis, and they will not know the exact answer. So in this particular case, we were fortunate to have another piece of biopsy from the rectum. You can see here, this is also eroded rectal mucosa. There are a cluster of organisms here. So these organisms have quite abundant cytoplasm, small nuclei, and with multiple ingested erythrocytes. So this diagnosis to many of them is not a diagnosis challenge. So this is Entamoeba histolytica trophozoides. So the diagnosis is apparently intestinal amoebiasis. So this is a PS stain that highlight the organisms which can be helpful. So this case apparently is a parasitic infection with prominent eosinophils. So in that case, you probably don't need to make a diagnosis of eosinophilic gastroenteritis. You say, well, this is intestinal amoebiasis. So what is eosinophilic gastroenteritis? So by definition, it is a spectrum of inflammatory disorders characterized by eosinophilic infiltration in one or more segments of the GI tract. So you can have eosinophilic esophagitis, eosinophilic gastritis, eosinophilic duodenitis, eosinophilic enteritis, eosinophilic colitis. They can occur in isolated form or in combination. We all know eosinophilic esophagitis is unique clinical and histological features. Like a patient typically present with dysphagia. Under endoscopy, you see characteristic stricture or furrows or rings. So it's quite characteristic. But they are not completely specific because in some other conditions like lymphocytic esophagitis or esophagitis with predominant lymphocytes may also show similar endoscopic findings with furrows, with stricture, with rings. So you still need a biopsy. So under biopsy, the pathology make a diagnosis of eosinophilic esophagitis by counting the intraepithelial eosinophils, right? By definition, you need to say 15 or more intraepithelial eosinophils in at least one concentrated high power field. And you better say that not only in the distal esophagus, but also in the middle or proximal esophagus. So since the diagnostic criteria for eosinophilic esophagitis it has been well established, so I'm not going to discuss this further during my talk. So as you can see here, eosinophilic gastroenteritis has multiple etiologies and disease associations. The most common ones will be infections, like the case I just showed you, the most common parasitic infection. And of course, it can be associated with fungal infection, bacterial infection, stuff like that. And food allergy, drug reaction are also two common etiologies. So you should always keep that in mind. And then there are a lot of disease associations, the frequently associated with inflammatory bowel disease, celiac disease, malignancies, polyps, mastocytosis, non-transcriptional cytosis, hypereosinophilic syndrome, connective tissue disease, including vasculitis. In some patients, disease does not have any identifiable clinical or histological etiology, so in those cases, the etiology will be idiopathic. So in the next few slides, I'm going to show you some examples of eosinophilia associated with GI disease. Like in this case, this is a classic case of inflammatory bowel disease, here specifically ulcerative colitis. So we all know in inflammatory bowel disease, lymphopenia typically show dense and mixed inflammatory lymphocytes with numerous eosinophils. And in that case, you should not give patients another diagnosis of eosinophilic colitis on top of IBD, because eosinophilia is a common finding in the setting of IBD. And then here's another example of celiac disease. So the lymphopenia is also heavily infiltrated with numerous eosinophils. Here you see the surface shows beta-splantin and intraepithelial lymphocytosis. So again, in the setting of lung etiology, we should not give another diagnosis of eosinophilic gastroenteritis on top of the original disease. So this is, you probably also paid attention to some polyps, like this tuberculoma. Here you can see there are tons of eosinophils. I've seen kinds of cases to rule out eosinophilic colitis on the polyp, like tuberculoma, which we should just ignore, because that's not an unusual finding. And here's an example of inflammatory polyp with numerous eosinophils with surface erosion. Again, so we don't make a diagnosis of eosinophilic gastroenteritis when the specimens are polyps. So this was a biopsy from a 57-year-old man who underwent colon cancer screening. And then a 5-millimeter polyp was found in the ascending colon, and then which was removed. So here you can see under histology, you see a small nodule lesion in the sun mucosa. And then even at low power, you see there are numerous eosinophils here. But in addition to that, you also see some short spindle cells with quite bland nuclei and pink cytoplasm. The cell borders are indistinctive, but again in the background of eosinophils. So we did immunostains, and it turned out they are positive for CD1A and non-green. So the diagnosis is non-transcriptional cytosis, which is not that common in the GI tract, but you do see them. So that case just illustrates that the necessity of looking for additional cell types when you see unusually excessive eosinophils, particularly when the biopsy is from a local or polyp lesion. Mastocytosis is another example like this, but I'm going to talk about it a little more later on during my talk. So we all know eosinophilic gastroenteritis has been traditionally divided into 3 types based on this 1970 landmark paper. So there are mucosal type, mural type, and serosa type. Each type has its unique clinical pathological characteristics. So the patient with mucosal type typically present with diarrhea, GI bleeding, or proteinuria nephropathy. And then, so the diagnosis can be made by endoscopy biopsy. So the mucosa biopsy would show increased number of eosinophils. Eosinophils may show degradation, and or you may say cryptic abscess or eosinophilic cryptitis, cryptic abscess, or you can say various beta-splantin if the biopsy is from small bowel. And then the mural type requires resection or full thickness biopsy to make a diagnosis, because the eosinophilic infiltration is limited to the muscular subcorpora. So the patient with a mural type would show abdominal pain or bowel obstruction, they show nausea, vomiting.
With why we need a new medication. This is showing you the pill called tenofovir alafenamide. The commercial name is Venidi. The pill size is very small. It's just a projector and looks big. So the reason we're using the new medication is in the future, hepatitis B treatment have to be a combination, just like HIV. So the pill smaller, have more potency, actually can serve as a backbone therapy for combination therapy. Now, before we put your patients on Venidi treatment, here's some of the safety information you should be aware of. Of course, you should monitor your patient for exacerbation of hepatitis B. That means their ALT could be elevated during the treatment. The other things that you watch out for at the bottom is you must rule out co-infection. For example, HIV and hepatitis delta. Nowadays, there will be a treatment available for delta too. Let's just start with some of the 101 for hepatitis B. What is the disease burden since you're practicing in the Asian community? Here shows that the prevalence of hepatitis B in the United States, approximately 2 million. That's a very conservative treatment. That doesn't take the non-documented patients, considering those prevalence among those prisoners. So 2 million is very conservative. Approximately 80% of them actually not knowing they have hepatitis B. So it's very under-screened, under-treated disease. The burden of hepatitis B actually translated to more complications like cancer and cirrhosis, approximately 40% of lifelong risk for cancer. And 15% of those patients actually develop hepatitis B may die from HCC or cirrhosis. So the treatment's still low. As you can see in this as data presented, the primary care physician see the patient and then refer to gastroenterologist or liver specialist, and eventually the treatment gap is still significant. Like any other disease, chronic disease, you're never seen as a lower treatment rate when compared to diabetic hypertension. So there are a lot of room for us, everybody in the room, to screen your patient and put them on treatment. Now, if you screen your patient with surface antigen positive, then the next step is try to determine the viral load and see if they qualify for antiviral treatment. Just a couple of months ago, the U.S. have updated universal vaccination. So everybody now, if you screen your patient negative, you should vaccinate them. Screen positive, if viral load more than 2,000 IU, pretty much is qualified for patient for treatment. Or alternatively, you can do FibroScan and see if patient have fibrosis, stage 2 and above, you should offer treatment. Now, what you should use, here are the first line treatment list up here. Venidi is one of them, compared to the old medication version called Variant. That's a tenofovir 3 milligram once a day. And another first line is entecavir. The new medication Venidi actually show that it's a safe for renal patients, and also compared to entecavir, Venidi actually could be a good choice for those patients that have predisposition or have been treated with any nucleoside antiviral, such as lamivudine, talvivudine, because they have a higher chance of cause drug resistance. Now, why we need a new medication compared to Variant? Here shows the plasma concentration of TAF or tenofovir alafenamide, the new drug, so in the blue. And compared to the old drug, actually the plasma concentration is much lower, but instead intrahepatic concentration of TAF is much higher. So therefore, the variant you use 300 milligram, you only need to use about 1/10 of that dose. That's a 25 milligram because 90% of the medication gets to the liver. Now let's just start with some clinical scenario. This is a hypothetical case. This is a Chinese patient, Zhang, and presented to you with surface antigen positive. Of course, the E antigen is positive too, anti-E is negative. So it's a E antigen positive patient. If you look at the viral load, it's more than 2 million. So based on the treatment criteria we mentioned, surface antigen positive, and then you need to test the viral load more than 2,000, which is in this case, it's an indication for treatment. Now, what if this patient doesn't have a 2 million viral load? Then you probably have to look at the fiber scan or fiber test with the blood test. Even without liver biopsy, you see at the bottom, patient have stage 2 fibrosis. And also that criteria qualify your patient for treatment even with a lower viral count. So what are the clinical data suggest that we can use variant in appropriate setting or public candidate? Here is a clinical trial, 108 and 110. Let me dive into a little bit for the study design. It'll be complicated. This is a randomized controlled trial, 2-to-1 ratio. 2 goes to TAF and 1 goes to TDF. That's the old medication. And those patients would be under blind randomization and taking the variant versus TAF for 48 weeks and then move to 96 weeks. At that point, supposed to be open label, but FDA decided to prolong the blind phase. Therefore, from 96 weeks to 144, you have some patients that have been open label. The others continue to be blind and treated. Now, all the way follow up to 384 weeks. Here's the study evaluation endpoint, primary efficacy, check on the 48 weeks, and then 96, 144, eventually 384. Here's the study population. Why it's so important? The take-home message from this is you can see majority of patients enrolled in this clinical trial actually are Asian patients, since you practice in Asian community. So this data are actually more applicable to your practice. And also there are some small portion of those patients that have been treated with different antiviral at the bottom, like entecavir, lamivudine, and adafovir. So here's the efficacy endpoint. That's showing these two drugs, what is the difference if you put the patient on. Now, the blue color represent new drug path, and TDF is in the dark gray color. And shows that if you have look at the subgroup of E antigen positive versus E antigen negative, they're pretty much the same in terms of ALT normalization, but significantly more patients in TAF treatment have normalized their ALT, as shown in the blue bar, much higher than the gray bar, starting from 48 weeks all the way to 144. It doesn't matter whether it is E antigen positive or negative, but more significantly showing the E antigen negative population and the ALT. But on your far right, on your far left, the HBV DNA did not show any superiority either which drug you use. So bottom line is the efficacy is showing the ALT difference, not the HBV DNA. If you look at the long-term follow-up all the way to 240 weeks, you see two viral dynamic curve. They are almost superimposed. Even you switch later on after 144 weeks, your open label switch from TDF to TAF, and you see there is not that much difference in terms of the HBV DNA suppression. And now let's get back to a long-term follow-up, 240 weeks, looking at the ALT normalization. And you see there are some difference starting from 48 weeks. But after you switch the old drug to the new drug from the dark gray color curve, and eventually at 240 weeks, two medications, ALT normalization rate is about the same. So in other words, is if you want your patients to have their liver inflammation well controlled, even they have been on the old medication.
Came out sometime in May, so it's fairly new. So you may that's why you may not know about it, and your pharmacy may not even know about it yet. But hopefully after today, you'll know more about this medication. Oh, sorry. So again, this is sponsored by Idorsia, so you're not getting CME in this next half hour, but hopefully you'll have plenty for the rest of the afternoon. We'll talk about advancement in the treatment of insomnia of this brand new medication. There are a lot of unmet needs for insomnia, right? Anybody here in the room actually experience insomnia? You don't have to raise your hand, but it's a very common problem, right? A lot of our patients, we do treat a lot of people with insomnia. And this one is not just going to hopefully not address the nighttime symptoms, but as well as the daytime symptoms, which we never talked about before until now. So if they've done surveys on patients with insomnia, and you see here about 73% of patients have reported difficulty falling asleep. But a good number of patients actually report it interferes with their daily living, their daily life. They feel tired the next day. They can't function at work. They can't function with school. They can't remember, like their memory is going down. They think it's maybe the medication actually, but it could be related to insomnia. So just a review of the DSM-5 criteria to be considered insomnia. You should have having difficulty sleeping, either falling asleep, initiating sleep, or maintaining sleep, or that you wake up early in the morning and you can't get back to sleep. And it's been going on for at least 3 months, 3 times a week, right? That's the definition assigned from DSM-5. But what a lot of us don't probably remember is there's actually a daytime component to that too. They must have some clinically significant impairment, like I mentioned earlier, whether it's social, work, educational, behavioral, so there's some daytime component to it. So this is the goal now for a lot of the insomnia medication. It's not just to help with their sleep, but also improve those daytime impairments. So this is what QUVIC comes in. So this first medication that actually evaluated both the daytime and the nighttime symptoms. This is indicated for patients with basically difficulty sleep onset or sleep maintenance. And the only contraindication if their patient has narcolepsy. You cannot give this drug. Okay, so that's easy to remember. So we'll talk about the trials that got this medication approved, and all this, what I mentioned earlier, but the nighttime and the daytime symptoms, what they've evaluated with the nighttime symptoms are 3 components. If you're not a sleep medicine specialist, this might be a little hard to remember from your med school, because I never remember this abbreviations. The LPS, that actually means latency to persistent sleep. That's basically the same thing as how fast can you fall asleep, right? How was the sleep onset? And the second one is WASO, week after sleep onset. How long do you stay asleep once you fall asleep? And then there's a third component, is what is their subjective total sleep time. So this is not something you can quantify yourself. You have something you ask the patients, so it's very subjective. How much total sleep time do they think they have? So those are the 3 components that were measured in this trial. The first 2 were actually measured through a sleep study, and the third component is a subjective, like I said, through a questionnaire to the patient. And then they also looked into the daytime symptoms. Again, these are all subjective as well. It's really hard to measure this objectively. You can't measure this from a sleep study, right? So their basic came up with this called IDSIQ. It's a longer term, I can't actually never remember, but it's insomnia daytime, gosh, I can remember the SI, but it's an evaluation of their quality of symptoms the next day. Like how energetic they are, how awake they are the next day. So it's basically a measurement of their daytime function. Some of the side effects that are reported in this drug, we're going to talk some more about this later on. Headache is probably the highest percentage at 7% compared to like a 5% placebo. And there are some people who do have some next day somnolence or fatigue and possibly dizziness, a small percentage, which we'll go over again later. So there's 2 doses for QUVIC. There's 50 and 25 milligrams. And they've shown in that trial that the 50 milligrams actually work very well, especially for the daytime symptoms. And we're going to talk about all the trials that were done. And the good thing about this QUVIC is the half-life. It's about an 8-hour half-life. So it's perfect timing for your patients that you want an 8-hour sleep. So this is not something you take in the middle of the night. You wake up in the middle of 2 in the morning, you can't take this. You got to have at least 7 hours of sleep time in order to not avoid the side effects the next day. So this is the trial. There was, like I mentioned earlier, they evaluated the higher dose, the 50-25. There was another study that studied also the lower dose as well. And then they followed them for 3 months to see what the effects are a month later and 3 months later. And then a small group of people actually were studied further on for up to 40 weeks, almost a year, and what happened to those patients, how they're doing with the medication. And there are about 1,854 patients in these 2 trials. So again, I mentioned to you earlier that the things that they measured, those through the objective measures through a sleep study, and then the subjective symptoms that the patient reports. So the IDS-IQ that I mentioned to you earlier, some of those questions, like I said, involve sleepiness and their mood, as well as their alertness and cognition. And they're usually 4 items, and they have to score them from 0 to 10. So the higher the score, the worse it is for the patient. So the goal of this trial is if there's at least 4-point reduction in that score, right? If there's a 4-point reduction, it's a significant change. So who's included in this trial? These are patients that are at least 18 or above. They had to have a history of chronic insomnia. If you look at some of these numbers here, these are pretty moderate to severe insomnia patients. So these are your patients who have had this for a long time as well. A lot of them have had this for at least 3-4 years. So these are your very, very, you know those patients, right? You have those patients who just can never sleep. These are your patients. Who's excluded from this trial? Those who may have some sleep apnea or other sleeping issues like restless leg syndrome. Like I said, narcolepsy is contraindicated, so they're not included in this. Or if they have a severe depression or severe psychiatric condition, because you don't want to basically consider the comorbidities with this patient. So those are the patients that were excluded. These are your patient characteristics for those patients who were enrolled in this trial. About 2/3 of them are women, and you can see the mean age is about 55. And you can see the ethnicity background, unfortunately it's mostly white, but you can see the background with our black patients and Asian patients as well. And like I mentioned earlier, the insomnia severity index at 19 is pretty severe, like moderate to severe. So these are your patients that are having issues. And like I mentioned earlier, the average is actually more than 10 years about having insomnia. So this is one way, this is the sleep onset results. So what happened? After about a month and after 3 months, you see the significant reduction on how fast they can fall asleep when you compare it to placebo, which is on the very left. And then the middle one is the lower dose, the 25 milligrams. And then the 50 milligrams, you see a significant drop in how fast they can fall asleep. So I always tell people the 50 milligrams is always going to be better. And I'll tell you more about when to use the 25 milligrams. Same thing with how long they stay asleep. You can see a significant change after a month later and 3 months later. And actually for me, what's interesting about this, it's the same from month 1 to month 3. You know how some sleeping medications you take, it work for them for the first week or 2, and then it stop working, right? So this is different. It continues to work even 3 months later. And I'll even show you the 40-week data in a little bit. This is the subjective ones that I mentioned to you. How long do you think people stay asleep? How much sleep time do they have? And you can see also there's a significant increase from the placebo after a month, and again, same thing for 3 months. And even here, actually, people's sleep got better 3 months later after a month. So this is a medication that continued to work. So this is one way to look at the graph and the difference between the 50 milligrams and the placebo. You can see the change is in the total sleep time. And then if you extend it to 40 weeks, it persisted. So you can see that the medicine continued to work even 40 weeks later, almost the same as it was from 4 weeks from the 4-week data. So this one continued, persisted, even though they stayed on the medication. And you can see the difference between the 50, the 25, and the placebo. What about that IDS-IQ that I mentioned to you? What happened to how many people actually had a drop in that significant drop from their daytime functioning? And you can see here the difference. This only made actually difference with the 50 milligrams. It did not make a difference with the 25. That's why I highly recommend using the 50 milligrams for this because of this part of the trial. There's a significant drop, meaning a significant improvement in the daytime function with the 50 milligrams. 1 month later and again 3 months later. This is another way to look at it through the graph. And this is what happened 40 weeks later. Like almost a year later, that improvement persisted. It continued, sometimes it can continue even better. So there's definitely some medication that persisted. It's not just a short-term relief for insomnia. So what about side effects that I mentioned earlier? I mentioned the headaches is the most common one, and then you can see some of the percentage there for fatigue and the dizziness and nausea. If you can see, there's not a lot of difference between the 25 and the 50 milligrams when it comes to side effects. So you know how sometimes we dose our patients, give them lower dose just to see how they tolerate it, to make sure that they're fine? You don't need to do that. The difference between the two doses when it comes to safety profile, pretty similar. So you don't have to do the experimenting of using a lower dose. So when they also evaluated these patients who stayed in the medicine 40 weeks later, they found that there's been no evidence of any physical dependency, even if when they stopped the drug. There's also been no evidence of any patients who had withdrawal symptoms when they stopped the drug. And there's no rebound insomnia, unlike some of the medications we have for insomnia, where you get rebound insomnia. There was no evidence that when people stopped taking the drug, they did not have any rebound insomnia. So because of that study after 40 weeks, there's been no new safety signal or any evidence for all those. So it's a drug that could potentially work for your patients without the risk of stopping the medicine. Some warnings and precautions. I'm just going to highlight some of them here. Because it is a sleeping medicine, it can impair their daytime wakefulness. Like I said earlier, you should really tell your patients they have at least 7 hours of sleep, because the next day, if they take it at the middle of the night, they may not be able to function. If they have to drive, you have to warn them that to make sure that they don't fall asleep on the wheel, right? And then I mentioned earlier, every sleeping medicine has the risk of